morning, guys. Welcome to Heart Attack Week. Yay, heart attacks. Okay, so let's talk about first the symptoms of a heart attack. What do people feel? Well, when they first started asking people and compiling a group of symptoms, guess who they asked? Does anybody know the demographic of people that they actually asked about, that had heart attacks that were confirmed, and then they asked them, what were your symptoms? Well, they actually asked white men. So we have to understand that the typical symptoms that we understand are not necessarily for everyone, okay? So we'll talk about the typical symptoms, and then we'll talk about atypical. So men are kind of the typical symptom category people, right? So they complain of, this is the easy part, chest pain, right? Arm pain. They might say they've got neck pain, jaw pain. They might have shortness of breath. All right, and then women don't fit into this. We are atypical, and also diabetic patients don't fit this as either, usually, okay? So these atypical people might have all of the typical symptoms, or they might have none of them, or they might have maybe the chest pain, or maybe just the shortness of breath, right? Now, the atypical symptoms that we talk about usually have something to do with the abdomen. So, it's usually nausea and vomiting. It could be abdomen pain. They could also have shortness of breath, dizzy, fatigue. They don't feel well, some pretty vague complaints, which is a little bit scary because if you think about that, how are you supposed to know that they're having a heart attack if they don't give you the clue that they're having, typical heart attack symptoms? Okay, so what does the older generation usually say? I like to talk about this because I've encountered this quite a lot as a nurse. So what does the older generation usually say when you ask them if they're having pain? Quite a few of them, and maybe not all the older generation, but quite a few of them will refrain from using the word pain because maybe they view it as a weakness. And so they might use another word and it starts with a P. And so they're going to say, I don't have pain, I have pressure. I don't really have chest pain, I have chest pressure, okay? Now when they say the word pressure, just translate it in your mind to pain, okay? And then you might have to translate the pain scale to be a pressure scale so that we can actually get a number out of these folks and figure out because they are having pain, it's just they don't interpret it necessarily as pain. So, but you still have to treat it that way. So let's talk about the pathophysiology of coronary artery disease, right? So here's our normal artery, our coronary arteries, and I'm assuming, there's probably a little bit on the edge, maybe not, maybe so, okay? But then for whatever reason, currently up for debate with the clinical world and research, somehow we make a bunch of plaques. And they contain different things, mostly cholesterol, right? Bad cholesterol. Don't know how those plaques form in some people that have a high cholesterol diet and not in others that do have a high cholesterol diet, right? So here is our normal coronary artery. We've got it longitudinally. And these are our little red blood cells, excuse my poor artistry. Here's our cute little red blood cells traveling through, okay? Unobstructed, totally fine. Then we got some plaque on our cross section forming. And so then you lose a little bit of your diameter, your circumference, right? And so you lose, you compromise a bit of the volume in your lumen that it can be capable to hold, right? And so then we get these little scabs, not really a scab, but a scab of one of the bits of plaque as the red blood cells are rushing by at a high velocity. Due to, these people might have associated hypertension or whatever. And so as they're driving by, they might accidentally, break off just a little bit of the plaque. Well, your body then turns this into an immune coagulation response because we have a bit of an insult to the tissue. We have some of the plaque that's ripped off, and so it treats it kind of like a scab, or it tries to form a scab, okay, in the artery. And so that triggers clotting, so that we have a clot form in that artery, and so then you get a complete block, or mostly blocked, right, of that coronary artery, which then you get a, ta-da, acute myocardial infarction. So that's kind of the progression of events. But this sort of event with plaque formation, we know that it takes decades. This kind of thing tends to happen in a shorter period where that plaque bit is broken off, and then emergently we've created a situation where they make a clot, and then their vessel is occluded. Okay, so before we do anything for these people, we want to, well, that's not necessarily true, but during the time that we are intervening for these folks, we want to tease out some sort of history from them, okay? So there's some really good questions we want to ask, and the acronym is OPQRST, and then an A at the end, but that's not necessarily, super necessary. So we want to know, when it started, what were you doing when it happened? So it's kind of like our interrogation, right? So what were you doing when this crime took place, and when was it? That is otherwise in the medical world known as onset. So we want to know the onset. When did this start? Give me a time, okay? And then you can ask them, what were you doing when it started? Were you exercising? Were you walking? Were you, hauling hay? Were you shoveling your driveway? All these different questions we want to ask, or this might be more foreboding, were you just sitting still, right? That's a bit of a, that's ominous, right? Okay, but we need to find out what they were doing. So we also want to know the P word, 2 P words, which has to do with what makes it better, what makes it worse. So what provokes your pain, and what palliates your pain. So palliative care, remember, in medicine is something where we are trying to alleviate. And so palliative means something that alleviates it. So what makes it worse? What makes it better? Okay? Then we want to talk to them and ask them about the quality. Okay, that's where you get your adjectives. So that's where people start saying things like, an elephant sitting on my chest, feels like a crushing pain, feels like my heart's in a vice. So that's where you ask, what does it feel like? Okay? Then we got our R's and R's. So we want to know where is it, and where does it go, right? So radiate is where is it going, other than what you're saying, and then region. So radiate and what region, okay? So we know they might have chest pain, they may not, but we want to know what else, where else is it going? Where else do they have pain? Okay? Then we want to know S. That has to do with the pain scale, right? Our 0 to 10 pain scale. So we want to know how severe it is. So the severity, okay? And then lastly, we want to know time. How long? How long has this been going on? 5 minutes, 10 minutes, 3 hours, 4 hours, okay? This is different from onset, because onset, I want to know when it started and what they were doing at the onset. But time is how long is this happening? Okay, now, then we want to know, are you on any anti-coag meds, right? And we would also want to know about a different type of medication that some men take for erectile dysfunction. We want to know about ED meds, because that will affect their ability to receive treatment, the different treatments, right? Okay, so stable versus unstable angina. So angina is that chest pain. that people report, right, when we have those coronary arteries, whether they're spasming, whether they're occluded, okay? And so they have associated chest pain with that. Now, what's the difference between stable and unstable? Okay, well, it has a few differences as far as the onset, the things that make it better or worse, and how long it's been going on. So onset is, so remember the onset was when and what. So this is going to pertain particularly to what. What were they doing, okay? So these people with stable angina are going to say the onset was with some sort of exertion. They were doing something, okay? They were shoveling, baling hay, whatever, right? They were vacuuming, lifting something, right? And so now we have exertion. So we're exerting ourselves somehow, and then chest pain starts. So that's stable angina. And then we have versus unstable. What's the onset for unstable? Does it happen with exertion? Yep, it does. But what distinguishes it between stable and unstable? It also happens when it shouldn't be happening. It happens at rest. It should not be happening at rest. They shouldn't be having chest pain when they're supposed to be resting, right? Okay? So that is ominous. All right, now, how do we get stable angina better? How do we know if it's stable angina? Is it going to get better? Yeah, it will. With what? What can we give to make it better? So, as far as the patient reports, they can say, well, I was shoveling snow and my chest started hurting, so I sat down inside my house for a minute, and after about 5 to 10 minutes, the chest pain went away. Cool. So I would classify that as stable angina, not unstable. Now, the unstable angina people, it does not get better with rest, and it can get better with nitro, but usually not nitro, okay? So usually nitro won't relieve it. So you can see how this is classified as unstable because it means that something much more worse is happening, right? And then our time is a bit different. So with stable angina, we have less than 5 minutes that it's been going on. And then we got our unstable peeps, and they're greater than 5 minutes, right? And they're not responding to rest or nitro, okay? All right, so that is stable versus unstable angina. Okay, now, what's our ER chest pain protocol? From the time the patient walks in the door, we need to do something very, very, very first. So if you suspect that someone might be having an acute MI, how do we diagnose it? What's the number one diagnostic tool? And it can be done really quickly, can be done by a tech, and then it prints out, or a nurse, or respiratory therapy. It prints out on a little printer thing, and it's at the bedside, or it can be done in the lobby, and then it goes to the provider, right? So that is, we're talking about an EKG. But not just any EKG, we're talking about a 12 lead, specifically, okay? Because we want those 10, we want all 12 pictures, right, of everything that's going on in the heart, okay? And that is where they put the 10 stickers on you, they put 10 leads on, takes a picture from all different directions, and we can diagnose if you're having an acute MI. And then we can also ballpark whereabouts in the heart, depending on which leads are showing that ST elevation. Okay, so it's really important. This has to be done. How long do we have from the time the patient walks in the door till the time that we get an EKG? We better be printing that EKG, and it better be done within how long from patient arrival? Not very long. 10 minutes. We only have 10 minutes, so you gotta move quick. Okay? And then we want to get some vital signs, we want to get history, And the history includes this stuff down here, our history questions. Okay, so that's where we ask, when did this start? What were you doing? What makes it better? What makes it worse, right? All of those questions. Okay, then we want to get 2 things done, 2 interventions done pretty quickly within the same amount of time. So we want to keep their sats above 90%. So we would put oxygen on them to keep sats above 90%. And then we also need something before we can move on to anything else. You need something before you can give nitro. You got to have this. And this is why they've kind of taken away the MONA acronym, because we want you to think before you give nitro. There's a few things we want to make sure is okay before we give nitro. So we want to make sure they have an IV, okay, before. So that's kind of the time where we're going to want to be doing it. Then we also want a certain medication that is chewable, 325 milligrams. So an adult aspirin, abbreviated as ASA because it stands for acetylsalicylic acid. Okay. Really quick, salicylic acid is the active ingredient in acne medication, and a lot of different acne medications, and it comes from willow bark. So that's why the Native Americans had aspirin before we did, because they were already using it as willow bark. So kind of interesting. Then we have to have, remember, this is to remind you, we have to have an IV before we give nitro. You cannot give nitro without an IV, okay? All right, now we're going to talk about that in just a second, why we can't give nitro. So we do nitro after we have an IV, so that's step 5, right? Sublingual times how many doses? We want a total of 3 doses, but you have to give them 5 minutes apart. Now, do we just give them every 5 minutes on the clock, no matter what the vital signs are looking like, no matter what the patient looks like? No. You got to use your brains, okay? So there are some things and reasons why we would not continue to give nitro, and that plays in with why we need an IV. So think about that for just a second. All right, now, if our chest pain is gone, obviously we're not going to be given more, right? If our blood pressure is too low, and we'll talk about too low in a minute, okay? Now also, people are going to complain of the most common side effect of nitroglycerin. Nitroglycerin is a really potent vasodilator, right? It dilates everything. So if we vasodilate everything, especially here and here, it's going to give us a headache, because headaches are usually caused by massive vasodilation. And so, if they complain of a headache, is that bad? Nope. It's a very common side effect, and it means nitro is effective, right? Now, when I say effective, it may not mean that it's actually lessening their chest pain, but you know that the nitro is actually still good, right? So when people take their expired nitro from 10 years ago, they may or may not get that headache. So you kind of want to see. But there again, not everybody gets a headache from nitroglycerin. So we just want to make sure that if they have normally gotten a headache, they're getting a headache. And then this also helps, I talk about this because it helps to assuage their feeling of panic. A lot of people, they don't like that headache, and rightly so. And so it's a good way to segue into, this is normal and this is what we were expecting. Okay, this is not unexpected. And then you can just, briefly tell your patient, this tells us that the nitro is working effectively and doing its job, right? Okay. So then if the nitro doesn't work, then we can give morphine, because we got our 3 doses of nitro, we can't keep going. And then if the chest pain is unrelieved, right, I already said this, unrelieved by nitro, then we give morphine, okay? And then defer to your hospital protocols as far as pain management after you've already given nitro and it hasn't necessarily, all 3 doses haven't worked, or you have to stop. Then I would defer to your hospital protocols for that, for the dosing on that. And then, the dosing on morphine is usually provider dependent. So just make sure you have a conversation with them and they put in the order. Okay, so then we got portable chest x-ray. Okay, we want to get this done, not the very first thing, which is why it's down the list, but we want it within 30 minutes of arrival because we want to rule out what? There is a really bad thing that happens. People will report chest pain. They will also report a tearing sensation and a pain that radiates through to the back. And if this ruptures inside them, if we don't fix it soon enough, if it ruptures inside them, they will usually exsanguinate or bleed to death inside within 1 to 2 minutes. It has to do with the aorta, and it's called a dissecting aorta. Okay, so that is a separate pathology, but we want to make sure that they don't have this problem, because it also mimics, it has chest pain. And so we want to make sure it's not a dissecting aorta, and you can see that on a basic chest film if it's really, really bad and dissecting enough. Obviously you can't see it as well as a CT, but you can see it quick to make sure that they don't have the hallmark mediastinal widening, okay? So then we have labs that we do, right? And that can happen at the same time we're doing the IV. So we draw blood, do IV all at the same time, but eventually it needs to be happening. So CBC, CMP, we want a troponin, yay, right? Because that's what actually measures our heart cell, right? Heart cell damage. So that's dependent on those cardiac cells. CK, CKMB are not really heart cell specific and more specific to skeletal muscle. And so this one is specific to cardiac muscle, okay? But from the time the chest pain starts, or the time they have symptoms, because not everyone has chest pain, from the time that they have symptoms to the time that the trope will be elevated is how long? Does anybody know? It's hours, it's in hours. So it will usually be elevated 3 to 4 hours from the time